All right, here we go with the last part of patient safety considerations when using fluoroscopy. In this section, we're going to cover clinical uses of fluoroscopy in pediatric medicine. We've pretty much covered everything that is relevant for radiation protection, with the basics of some of the physics. And again, this is not going to be sufficient for you to pass the exam. You will certainly have to study some more. Again, I recommend some of the question banks if you are in that situation. But the things I covered in these prior lectures are really the things that are supposed to give you an understanding of what radiation protection principles are useful to you. This section is going to be a little bit different. I want to cover some of the that seem relevant in pediatric medicine that I can suggest based on my prior fluoroscopy experience. Now, obviously, many of you have used a lot of fluoroscopy in the past, and the clinical guidance from me may not be all that useful. Going to basics of radiographs, right? Just keep in mind they can only detect for different types of tissue densities, although there's certainly a gradation there. Right? We can detect very dense objects like metal, which will show up bright or white on our X-ray and then dark on our fluoroscopy image. A fluoroscopy image and X-ray image, they're really just inverted images. Bones showing up in their typical light gray, soft tissue, the dark gray. Sometimes you can see muscle definition in those soft tissues, although again, soft tissues like fat and muscle are very close to each other, so we don't get a lot of subject contrast. And then gas, any kind of air, which is going to be black. You can acquire images either 2D or 3D. So most of the times, 3D images are generated from CT, but it is actually possible to generate 3D from fluoroscopy images if you acquire multiple planes. And if you do that occasionally in interventional radiology, when we want to look at a typically hepatic lesion, not something I believe you will be using in podiatry, but still interesting technique. So one of the most important clinical pieces that not everybody seems to know is that really one radiographic view is no view. So I have here a couple of examples that really try to demonstrate this point, that you are looking at a 2D image that is a projection through exactly the area which your X-ray beam courses. So overlapping objects, you really are not able to distinguish if you are looking at it from one perspective. The challenge is that people kind of get a sense that they can, but you are really collapsing a 3D object into a 2D surface. So there is simply no good way to distinguish overlapping objects unless you have some kind of reference landmark. This here is a great example of a guy holding up a knife, and it looks like the knife actually is in the skull on the frontal image, but then on the lateral image, we can clearly see that that is not the case. Here an example of a distal phalanx fracture, which if you look at the AP view, it's basically impossible to tell that there is a fracture. I have the larger image that's blown up, and even on looking at a diagnostic monitor, you cannot see that there is any fracture. But then looking at the other views, obviously there is a actually mildly displaced fracture, but it's displaced exactly in plane with that X-ray that was obtained. And so you can see this if you only have a single view. Again, one view is no view. Another example. Here, a pretty striking dislocation. Again, the AP view, impossible to see. But then if you either oblique or obtain lateral views, it becomes quite clear. Moving into the pediatric realm, so here a lateral view that was obtained. I can't remember the details. I think the patient was had some difficulties holding still, so they only got one view. And you can see this little tiny fragment there. And once they were able to complete those pictures, we actually see a pretty significantly dislocated fracture there, which gave us this little fragment that we saw, but really very little indication on the lateral view otherwise. So there's a couple of things you want to keep in mind when you use X-rays in relation to anatomy. And again, that can actually help you navigate this one view is no view problem to a certain extent. So first of all, type of bone. Cortical bone is by definition denser and will appear more dense on X-ray, more opaque than cancellous bone. So the look of the bone can actually tell you what type of bone it is that you're imaging. Quite frequently you see osteopenia, and it's not just that the density is less, but you can actually see some bony changes related to the osteopenia too. So the bone may have a thinner cortex, a wider medullary canal, and that can be additional indication that there is osteopenia present and that you may have to proceed with caution in a certain bone since it is going to be softer. The articular surface actually has some multiple components here, right? We have that subchondral surface, which the subchondral bone generally appears a little bit denser compared to the surrounding cancellous bone and is more similar to cortical bone, even though it is cancellous bone. And you can use the fact when you're reducing fractures, that line of the more dense bone can actually be useful to make sure that you have anatomic reduction. Another important thing to look at is whether or not the surface that you're looking at is concave or convex. It can actually help you determine whether you're inside or outside of a certain object. So it can solve your one view is no view problem without having to reposition the fluoroscope. One example where this applies is actually the joint, tibio-talar joint, where you do have a concave and a convex surface, the concave surface being the talus and the convex surface in the distal tibia. So taking as an example the distal tibia, if you see that your instrument is outside of the joint on one single view, you can actually be pretty confident that the instrument is not inside the joint since this is a concave surface. On the other hand, just because you see your instrument outside of the talus in one view, because it is a convex surface, does not necessarily mean that you are outside, and you may require additional views to verify this. So a couple of clinical examples of how fluoroscopy is used, right? So we can use live fluoroscopy to demonstrate motion. I have a couple of examples here of that. So here, just simple joint motion in a patient with normal range of motion. And then actually some motion of one of the MTP joints here. We can see pretty normal movement. You can see the midfoot joint here, which does appear to have a little bit of laxity in this case. And this is actually one of the exams that clinically you may want to do under live fluoroscopy to be able to see the changes there. The other thing to note here is that you can actually see the operator's fingers in the image on the left. So again, sometimes difficult to avoid. Would be very difficult to image this without having the fingers inside of the field of view, since you need to manipulate that small joint. But when this does occur, do be aware that it is occurring and make sure to minimize the amount of radiation exposure. Another common use for fluoroscopy, obviously joint fixation, fracture fixation, where you may be using K-wires to get good alignment and then actually place screws, right? Again, you want to make sure that you, on a single view, are confident where you are. it does occur not infrequently that additional joints get penetrated, causing then secondary degenerative changes. Next, a nice example of fracture reduction, right? Again, this is surgical reduction. I don't know how frequently people still do closed reductions for fractures, since it seems like the majority are treated surgically if they are displaced, at least in adults. But certainly people used to do a lot of fracture reduction, closed fracture reduction under live fluoroscopy, which does help in making sure you get appropriate alignment are now actually in place. Here, a nice example of open fracture reduction in this patient with a pretty significant talus fracture. You can actually manually manipulate that fracture and feel that go back into place, right? And similarly in imaging, it's quite nicely demonstrated how you have adequate alignment at the end. Another clinical application, arthrodiastasis, joint distraction, which doesn't seem to be that common, but there are a couple of big proponents, most significantly a couple of orthopedic surgeons from the Hospital for Special Surgery in New York City that employ this technique, basically supposed to allow cartilage regenerate. So pulling apart the tibio-talar joint, and then so the theory goes is that the cartilage is bathed in this nutrient-rich joint fluid without being exposed to mechanical loads that may damage any ongoing chondrocyte regeneration, and this can help reduce pain from arthritis. Typically, this is combined with a joint in that external fixer that pulls apart the joint, allowing you to move the joint, making sure it does not get too stiff. The data on this seems to be a little bit mixed. Very good data from HSS, but otherwise the data is not that convincing from my perspective. Another clinical example here, arthroplasty, obviously. Lots of hardware that you can nicely see in fluoroscopy. Pretty significant role for fluoroscopy in ensuring you are well aligned. But here is actually a good example of an arthroplasty where fluoroscopy is a little bit, I'm not going to say misleading, but subtle in defining here. So this post-procedure it looks fine at first glance, but then if we actually obtain the post-operative radiograph, we can see here nicely that there actually is a medial malleolar fracture that was missed during the procedure. And so, obviously what should have happened is that this iatrogenic medial malleolar fracture would have been fixed during this procedure. Unfortunately, it was not fixed. So, we have this post-operative film that shows us this fracture, and this specific patient, went on to non-union for this medial malleolar fracture, didn't heal, had to get fixed surgically later on. Here, another nice example of motion and motion evaluation in a patient where it actually is clinically significant to see what that range of motion is. So a patient with a triple arthrodesis, total joint arthroplasty, a bunch of hardware related to prior intervention. And here we can see this patient has very little range of motion from that arthroplasty. So if there's any question about where any range of motion is coming from, what's the range of motion of individual joints is, fluoroscopy, live fluoroscopy can actually be very useful for that. The other piece with fluoroscopy is interventions, right? So arthrograms where you can actually inject contrast and better visualize the joint surface, which is not done as frequently anymore today with MRI, but certainly has a role in patients who are unable to receive an MRI. Just as a little detour, the patients where MRI typically does not work are either patients with a pacemaker being the most common. There's some aneurysm clips. There's some coronary stents that may preclude the patient from having an MRI. If the patient ever worked with any metal and actually has metal in the eye, we typically do not do an MRI unless it's critical. And if you have any questions about whether or not your patient is able to get an MRI, either the MRI technologist or the radiologist can look up the different devices and how they interact with magnetism. So just give them a call, but you do have to know what kind of device it is that your patient has. So getting back to the arthrograms, again, injecting the joint. The other reason why you may want to do that, which can also be done under fluoroscopy guidance, is injecting either diagnostic local anesthesia to see whether there's a pain generator in a joint, or injecting steroids to calm down any sort of inflammation within a joint. With the arthrograms, the nice thing is you can actually see what is being injected. So what some people do is actually use an arthrogram with lidocaine or an arthrogram with steroids, so you can see which areas the fluid actually goes into. But essentially, you go into the joint, you can verify that you are in the joint space, and then you can actually see how that fluid distributes throughout the joint. This can actually be quite useful since there's a number of anatomic variants where multiple of the joints may be connected. So I think about 20% of the population have a synovial sheath that connects the tibiotalar and subtalar joint. So you may think that you're injecting the tibiotalar joint, but because of the patient having this communication, you're also injecting the subtalar joint at the same time. And so you may actually be eliminating two pain generators, or eliminating a pain generator that you were not able to identify. So there certainly is added value of doing that under contrast with fluoroscopy. Here, an example of a subtalar joint injection. As you start going to the smaller joints, it becomes more and more difficult to inject these under anatomic landmark guidance. And so people more frequently use fluoroscopy. And the other thing you can do is actually use ultrasound. So it is possible to inject joints under ultrasound only without needing any fluoroscopy, including the smaller joints. But technique requires some practice there. Here an example of the talonavicular joint, which is certainly one of the joints that's a little bit harder to inject without any image guidance. Or at least that is my radiologic perspective. As a radiologist, of course, anything I do, anything I inject is ultimately under image guidance. But this is one of the joints that does appear harder to inject. You can actually diagnose ligamentous ruptures using arthrograms or tenograms. And this is not really done anymore. We have almost completely replaced this technique with MRI. But again, there's a certain number of conditions where your patient may not be getting an MRI. And if this is truly a clinical question you need answered, this is a tool that does exist, as being able to demonstrate ligamentous rupture using fluoroscopy. And in this case, we see an anterior talofibular ligament tear where we have this contrast extravasation at the place of the arrow. And here we see a more extensive rupture where we see actually contrast going into the peroneal tendon sheath. And so this tells us that there's not only an anterior talofibular ligament rupture, but also a calcaneofibular rupture, since that is a requirement in order for the contrast to enter the peroneal tendon sheath, at least in a patient with standard anatomy. Again, there are anatomic variants where that may be a connection that exists. So that's the other piece you need to know. Is this standard anatomy, or what is the appearance of some of those areas? Are they irregular, which would indicate some disruption? Similarly, you can do a tenogram. So directly inject the tendon sheath, see whether or not there is any irregularity to suggest that there is a tendon disruption. So I hope you found these couple of clinical cases useful. If you do have any questions about any of these materials, feel free to email me. I'm happy to answer anything that may come up, any suggestions about these presentations. I'll also gladly accept them. And here, this cartoon really just illustrating one of the biggest pain points as a radiologist, right? Anything we do as radiologists is ultimately documented in both the image and our report, which is the piece of our work. So malpractice lawyers obviously love that, and they can take the retrospective scope and take a look at some of the work we do. This brings me actually to one more clinical point, which is documenting. So you can typically store images and send images to PACS from your fluoroscopic device. So if there is something unusual, something where you need to demonstrate that patient had a finding, for example, with the joint laxity of the ligamentous rupture, you may want to document that. You do want to take those images and actually send those images to your PACS system, which is part of the clinical record. So you have this, you fully documented. Your words in the patient's note may not be sufficient in order to prove that what you're looking at is actually what you think it is. Now with that, thank you very much. I hope you enjoyed the fluoroscopy workshop. And again, if you do have any questions, feel free to email me.